Okay, let's get going. So yeah, just the usual sort of housekeeping thing. If you just keep your camera off and stay on mute when we're doing our sort of group talks here, that should hopefully avoid any sound issues or anything like that. Yeah, there's a Q&A, so if you do want to put any questions in about any of the general stuff, any of the general processes and things that we're outlining during this little bit, then please pop them in the QA. If not, then we'll be in this room for the rest of the afternoon. So when the other stalls are open, you can always come back in here anyway if you suddenly think of something you'd like to ask us. But otherwise, so yeah, so we've got about an hour now where we'll be just talking through all the general stuff, how to apply, what sort of subspecialties there are available through the paediatric pathway, some sort of eligibility bits, and some information on the kind of assessment areas. And we'll have Karin Schwarz, our Assistant Officer for Subspec, who will be running through some of that with us, and also Eloise, and myself. I'm James, I'm Head of Medical Recruitment at the college. So we'll also have some introductions from the subspecs that are on in the afternoon as well, so they will get a little 1 minute sort of spiel before you break off into your different stalls. So I'll crack on then. So these are kind of the main areas we're going to cover, kind of what is subspecialty training, where does it fit, and so on with the pathway. We'll talk about who can apply and when sort of standard times are for kind of doing that. We'll talk about, as I say, the kind of subspecialty you can apply for through the paediatric pathway, and also just give you a bit of info on how to approach any of the other ones that sit outside. We'll go through the recruitment process as well, and the confirmation of eligibility form, which is an important part of the application process. And then, as I say, Karen's going to talk through the assessment areas as well. We've also got Natalie Wyatt, who is at the top of the screen there, who is one of our trainees who has been through the process and is now having a great time in nephrology. She'll be giving us a little bit of info on kind of tips and kind of hints for kind of how to approach applying for subspecialty training. And as I say, we'll have some intros in amongst that as well. We're not covering spins. Spins are quite separate to subspecialty training, so we won't be touching on them today. So where does it fit? Where does specialty paediatrics come in? So it's the second part of the UK training pathway. So once you've completed core training and therefore completed all the elements of the RCPCH, specialty paediatrics is kind of the last indicative 3 years of training. So the standard place to apply for is from ST4, but you can apply a bit later on. Essentially, pretty much all of the paediatric subspecialty programs are about 2 to 3 indicative years' time to complete. Obviously, the further you get down the training pathway, the later you apply, the less time you'll have actually in the official training. So therefore, you are able to count experience that you've done before you join. So therefore, you can get experience perhaps via an OAP, or whether you've done a couple of rotations that you've managed to get through your region, then you can use them to count towards the capabilities that you need to sign off and get your CCT. So that's a discussion that you'll need to have if you are sort of either applying again later on, or whether perhaps you've just come to the particular sort of subspecialty that really tickles your fancy much later on in training. So therefore you can apply, but with that sort of extra bit of experience behind you. The important thing to say is this is the one way in the UK training pathway that you can actually get a CCT in subspecialty, and therefore be on the specialist register as a subspecialty paediatrician. Other than the portfolio pathway, there aren't really any other kind of equivalents at all. So Jim's very clear on it. If you're going to be on the specialist register as a subspecialist, then you need to have gone through the national formal recruiting process. So that therefore means that anybody who's not in the UK training pathway, you can't apply from outside of that. So if you are not in the UK training pathway, you would need to join either SD1 or SD3. And we do get quite a few, particularly overseas doctors applying at SD3 who come and join the pathway, and some of them go on to apply for subspecialty training. The only couple of exceptions there are we do accept applications from Irish trainees, and also there are a couple of the other specialties that kind of have joint pathways. So intensive care, anaesthetics, emergency medicine will be the other sort of routes in. Pretty small numbers for each of those, but they are also ways of joining the program and going into the kind of formal subspecialty training. So the really key thing is if you are in the pathway already, therefore you have completed core by the time that you start your subspecialty post. So if you're applying this year, for example, that would mean that you're applying to start your specialty training next year, August or September next year. So you would need to be on track to complete core by that point. And that obviously includes all of the parts of the MRCPCH as well. So if you are taking the clinical in kind of the last sitting of the year, then you won't have had that confirmed by the time you're applying. But that doesn't mean you don't apply or can't apply. It just means that we need to check your result essentially before you're invited to interview, or confirmed invited to interview. So as long as you do actually clear the clinical before the interview period, then you'll still be able to make your application and carry it through. Just to say, you don't need to have a rotation in advance. Also, I've mentioned the kind of retrospective experience that can be counted if you're applying later in training. But if you're applying sort of ST4, ST5, you don't need to have done something formally in that specialty before. Very much like we say for ST1. Again, you don't need sort of formal experience before you join, but obviously it does help if you've had a bit of exposure to it. And a key part of the application process, particularly via the confirmation of eligibility form, is actually showing that you've actually put some thought into what you're applying for and that you understand what the specialty does, how it is to work in it, and therefore, I suppose, without some sort of exposure to it, that does become trickier, but it's not a prerequisite. So therefore, when you come to interview and so on and so forth, you're not going to be getting asked very in-depth specialty medical recruitment type questions, because the assumption is that you've probably only done a little bit beforehand as opposed to kind of a full rotation. Deferrals are possible, but only for statutory reasons. So that's in line with national recruitment for every specialty and subspecialty, which is under the NDRS banner and Medical Dental Recruitment Selection Group, which covers all of this work as well. So if you are sort of doing kind of either academic posts or anything like that, or anything perhaps, excuse me, which will involve you possibly starting something which means that you can't start the following August, September, then the advice is just to hold and don't apply the next year, because you won't be able to defer it on that basis. And that's the same if you get confirmation through of something after the recruitment process is closed. There is very little to no chance that your deanery will allow you to defer, and certainly if it comes back to the sort of formal recruitment process, that won't be a possibility either, I'm afraid. Applications open in October, so you've got time between now and then to start actually looking at the confirmation of eligibility form, and discussing with your educational supervisors and so on about what needs to go on there and the evidence you need to supply. And that, as I say, is for next August, September entry. I'll hand over to Eloise now, and she'll start taking you through some more of the process.
Afternoon, everyone. I'm Eloise, Medical Recruitment Coordinator at the college. So these are all the paediatric subspecialties that we recruit into. So there's 18 of them. Pharmacology are not recruiting in this round. They recruited last year. We also, not on the list, but child mental health do not currently have training posts, so we're not recruiting into them. But all the others, they should have posts in the next round, opening in October. So on the next slide, these are all the paediatric subspecialties that we do not recruit into. So you'll see the Royal College in the second column, and you'll need to contact them or the recruitment office and find out more about them. But yeah, unfortunately, we do not recruit into those. So quite a few stats on the screen. This is available to access on the website, so you can have a look at this in more detail if you'd like. So this is the kind of top stats for the last round. So the first column, all the subspecialties we recruited into, then the number of posts, then the number of applications, the number of applicants that were shortlisted, the competition ratios of shortlisted applicants to posts, number of posts filled after the interview process, and then the fill rate. And the bottom row you can see there are the totals. So as you can see at the top there, community child health and neonatal medicine, they had the most amount of posts and the most amount of applications. So I won't go into more detail on that now. As I say, it's on the website if you want to have a look in more detail. I'm going to go through the recruitment process kind of step by step. So the first thing that you'll need to do is to fill out the confirmation of eligibility form, which is on Riser. That's our e-portfolio platform. So if you're already in training, you'll recognise that platform. So it needs to be completed by yourself as the applicant, your educational supervisor, and then a final sign-off by your head of school or your training programme director. It must be with us by the application deadline. So we're just sticking with one deadline this year, and you must take responsibility for it to be with us by that deadline. If you are applying later in your training and you have less than the indicative programme length, so the programmes tend to be 2 to 3 years in length, but if you don't have that amount of time left, you can count up to 1 year whole-time equivalent of relevant experience, and it must be in the UK as well, and that's subject to CSAC approval. And you still have to have enough time left to complete the training programme. So do speak to your training programme directors about that if you're not sure if that applies to you. So the next stage is the oral application. So you submit your application through the oral programme. So again, if you're already in training, you'll recognise that programme. It opens in October for 3 weeks, and then we only have one intake. So you would start in August or September the following year, depending on the region. You can apply to a maximum of 2 subspecialties per round. And you must already be on an ARCP outcome 1 at the point of application. If you're on an OOP, so you would have an outcome 8, your previous outcome must have been a 1. And then we have the longlisting process carried out by the college. So that's a basic entry criteria plus the confirmation of eligibility form. So that's why it's important. It needs to be with us by the deadline. Then we have the shortlisting process. So we have shortlisters from the subspecialties scoring all the applications according to the shortlisting score sheet, which will be published on the website very soon. And the scores will get you to interview. They don't carry through to the final score. Once we release those outcomes, we also release the feedback as well. And then after shortlisting, we then have the interview process. And the platform we use for that is Cubicom. So they're all virtual interviews and they happen over 2.5 weeks at the end of January, start of February. And you must have completed your RCPCH examinations by that point. So if you're applying a little bit earlier, you may be applying at the end of your ST3 or ST4 year, but you must have your examinations completed by then. Otherwise, you won't be able to sit your interview. And then we have the office process. We release those via Oriel. At that point, you must have completed your core training capabilities to be able to be offered a post. You'd need to have achieved 60% or higher to be deemed appointable at interview. And the offers are sent out based on where you rank with your interview score and also your programme preferences. So there'll be more about that in the applicant guide and also at the time when we're sending out offers. And then if there's any unfilled posts left, then we have a clearing round. So not every subspecialty is included in this. Most of the subspecialties tend to fill their posts before getting to the clearing round, but any unfilled posts will be offered to the appointable candidates who haven't received an offer. Okay. And the next slide, please. So the confirmation of eligibility form. So this is the last slide before we start the first round of introductions from the subspecialists. The confirmation of eligibility form, as I say, it is on Riser, the ePortfolio platform. And there are some changes to it from last year. So if you did apply to last year, there's a few changes. So we will again be asking for 3 examples, or 6 if you're applying for 2 subspecialties, of your clinical activities or experience from your career. So they must show your interest and your understanding of the chosen subspecialty. This year, we're also asking for your most significant quality improvement project or audit project. And for both of these, the clinical activities and the QI project, we're asking for you to upload evidence from your ePortfolio. So to do that, you would have to download the evidence you've already got on your ePortfolio and then upload it to the form. This evidence that you use, they must be the same examples that you're going to use on your application form. So do think about those carefully, discuss those with your educational supervisor, because to get through longlisting, we will be checking that they are the same examples. The format of the form will follow the application form, so the questions will be the same and there will be the same word limit of 50 words. So do check your word limit carefully, because there isn't, we're not able to put a word limit on the Riser form, but you do still need to stick to the 50 words because in oral there will be one. So your educational supervisor needs to verify your answers. So that really is the reason that we're including those questions on the confirmation of eligibility form. So the answers for those questions have been verified. So they need to sign the declaration form, sign the declaration bit on their part of the form, which confirms that they've had the discussion with you and that the work is of your own. So then it goes to the head of school or training programme director, and they have overall sign off of the form. And as I said, it does form part of longlisting, and you need to make sure the form is with us by the application deadline. Okay, so at this point, we're going to have our first round of subspecialty introductions. So starting with allergy. Do we have someone here from allergy, please?
Hi. Hi, my name's Roz. I'm one of the paediatric allergy trainees currently working at St Mary's Hospital in London. So why would you like to do allergy? Well, actually, what people don't realize is that 20% of general pediatric conditions are actually atopic. So that's things like asthma, eczema, hay fever, food allergy, drug allergy. And if you like to have both a depth and a breadth of experience across the variety of subspecialties, then we are probably for you. Because of that, our training is quite diverse. gaining experience across all of those specialties, such as respiratory, ENT, gastro. We also cover, our curriculum covers a bit of ID and immunology. So it does suit someone who, as I said, wants depth and breadth. The specialty is mostly outpatient based, and so it would suit someone who is good at taking, so histories, being analytical, and maintaining an interest for a long diagnostic process. So particularly with the food allergy patients, they will come for a series of food challenges, often to confirm or to delabel their food challenges. Within that, we work well within our MDT, so our nurses, supporting our nurses to conduct the food challenges, supporting the dietitians who provide support to the family, and thinking about the type of person, you need to, as I said, be good analytical skills, and also to have be naturally curious, because many of these families come to you with a very vague history of what and concerns about what they need to, or what they're allergic about, and they're looking for both your diagnostic skills and some reassurance. So you need strong communication skills and genuine empathy, because you will be working with these families who are naturally very anxious and very worried about their parents, and you have the benefit of being able to walk through them for quite a length of time, developing a natural rapport and a longitudinal relationship with them. We're also a kind of emerging field, so people will have seen the headlines of the LEAP trials and putting peanut into children's diets as a treatment for food allergy, and so that is definitely something that is an emerging treatment, both for peanut and for other food allergens. And so if you like to embrace lifelong learning, staying up to date with research, and then being able to translate that into how that truly affects patients' lives on the ground, and bringing that into the NHS, then we're the specialty for you.
That's great. Thank you, Ros. Do we have someone here from Paediatric Diabetes and Endocrinology, please?
Yeah. Can you see me and hear me?
Yes, thank you.
Yeah, hi. So I'm Rathi. I'm a Peds Endo consultant, and I've been in the specialty now as a consultant for 10 years. I think it's an absolutely fantastic specialty. It's diagnostically challenging, and if you're a details person, it could well be the career for you. There is huge therapeutic potential once you do come to a diagnosis with hormone replacement, and there's real scope to use tech. You know, when you think about closed loop insulin pump systems, for instance. There's a lot of variety in our work. We work in big multidisciplinary teams, and we engage with a whole heap of different paediatric specialties in the hospital. And it is an extremely outpatient-based specialty. There's real opportunity for continuity in care as well. So you get to really know the young people and families you look after as you take them through childhood and adolescence. It's also an extremely exciting specialty from a research perspective. So whether you're someone who is extremely research active as a clinical academic, or as a clinician recruiting your patients to state-of-the-art NIHR portfolio studies, there's real opportunity for you to help take the specialty forward as well. And then finally, there's real scope to organise your time in the specialty. And I'd say it's a specialty where you can achieve a really nice work-life balance, which is extremely important as well. So I'd highly recommend the specialty overall. Thanks.
Thank you, Rathi. Next, we have Paediatric Emergency Medicine. I think we've got Julia here.
Morning. Sorry, my laptop's been a little bit
Morning.
slow.
Thanks, Julia.
Morning, all. My name's Julia. I'm a PEM consultant at the Royal Derby Hospital, and I'm part of our intercollegiate CSAC. Intercollegiate means that we recognise that training in PEM is across 2 training pathways within the RCPCH and the Royal College of Emergency Medicine. Our RChem trainee colleagues are the ones doing the subspecialty in paediatrics. We are specialists in undifferentiated presentations. In other words, we may well be managing a collapsed neonate, and we have to cover all of those differentials, and then it may take several hours, sometimes days, to work out actually what is going on with that little person. We therefore have a unique skill set, and we pride ourselves with working across all teams within the hospital, because we manage the paediatric medical problems, surgical, trauma. Our days are therefore incredibly variable. So we may well start with managing a febrile neonate, and then we'll move to a screaming toddler with a foreign body up its nose. We do love to deal with those ones. Then we might have a young lad who's fallen off their bike with a funny shaped forearm that will need all of your distraction techniques and some intranasal fentanyl and maybe some ketamine to sort them out. So we manage a very, very broad spectrum of conditions, and therefore we need a very broad skill set. That means our training is a 2-year training program. We have all of our trainees doing 6 months of paediatric intensive care unit to recognise the skills that are required there. And then we do 6 months or the equivalent of that time covering all of the surgical specialties, and that will include gynae, ENT, ophthalmology, dental, max fax, etc. And the rest of it will be, the remaining year is within the paediatric emergency medicine team itself. We obviously have to cover clinical interactions such as safeguarding. You'll need to manage flow within the emergency department, and we rely very heavily on all of our colleagues on the wards to move their patients through as well. Leadership, communication, lots of interface with our primary care colleagues. We're very aware that the teams in primary care are really struggling for lots of different reasons, and so the emergency department is the default for a lot of kids, complex or not. Those of you that are looking to apply, as we've heard from James, you apply in ST4 or maybe ST5 for a 2-year training program, because there is some flexibility because we're only a 2-year training program. There is some bespoke training involved because some of you will want to pre-count, and then we can manage that and we'll meet with you and go through that. We are all looking forward to meeting you in the stalls a bit later on. We can chat through any of your questions, and we're delighted to meet you all. Thank you.
Thank you, Julia. Next, we have paediatric gastroenterology.
Hi, my name's Neil. I'm a paediatric gastro trainee at Bristol Children's. I've been there for a couple of years, and I had worked in adult gastro before, which I really enjoyed, and then I enjoyed my time in district general gastro. And when coming to tertiary gastro, I think there was a few things I noticed that were different to my previous experiences, and ones I think you should be aware of and to entice you into the future of the specialty. So like some of the others we've heard, for gastro, clinical care for most patients is in the outpatient setting and across multiple subspecialties. So a huge body of work is with inflammatory bowel disease patients, but also lots of clinics in hepatology, nutrition, and celiac disease. And that is reflective across your training or within the training program. During service and ward weeks, you round on a few inpatients a day, some of whom have been there for a long time, have had long-term needs, but you also spend time consulting on other teams' patients where GI or nutrition issues have risen. So we have a huge bulk of patients who have neurodisability and often round on PICU patients as well. In addition to that, a fair bit of the time is spent taking calls from across the region. So we work as a hub and spoke model for Peds Gastro, with many of the DGHs linking into the tertiary centre. So we support doctors across the region by phone and including their nurses, and in particular for IBD patients, but also for any acute or acute on chronic GI presentations. You'll be pleased to know that gastroenterologists spend their time on call from home and don't often get called into the hospital. And that is that may be a key priority for you thinking about long-term career. We're a very practical specialty. Depending on where you work, about once a week or once every 2 weeks, you'll be performing upper or lower endoscopy or interpreting GI investigations such as pH studies or video capsule endoscopy. So we're quite a practical, heavy procedure-based specialty. And we have a very close working relationship with paediatric surgeons, in particular for infants with rare congenital disorders or those who've had operations. You also have a very close working relationship with an MDT filled with dietitians and pharmacists, parental nutrition team, and IBD nurse specialists who really lead on some of the inpatient and outpatient management of your patients. So I think there's lots of opportunities to discuss when it comes to the training program itself, and I'm really happy to talk about research opportunities, less than full-time opportunities, commuting across the country, and what the day in a life is like as a GI consultant and trainee in the breakout room. Thank you.
Thank you, Neil. And then our last introduction for the first round is from Paediatric Hepatology.
Hello, hi, I'm Rosie. I'm one of the registrars in paediatric hepatology at King's. I'm ST5, so doing my first year of grid training. In terms of why I think hepatology is a great specialty, we have a really big range of very interesting conditions that we look after. It's often very rare things, lots of weird and wonderful stuff, lots of genetic syndromes, metabolic problems, as well as the kind of surgical things that are maybe more common. There's a lot of diagnostic challenge, and lots of our patients have quite a long pathway to reach a diagnosis. We also look after patients undergoing liver transplant and also intestinal transplant, so that has its own specific challenges and kind of is its own interesting field. There's a big range in terms of both acute and chronic care, so most of our patients have long-term chronic conditions, and if you enjoy that kind of care, sort of getting children through their early life and towards transition, that's something that we do a lot of. But equally, when patients with liver disease get sick, they tend to get very sick, so we have a lot of acute care and a lot of working with intensive care as well. It's quite split between inpatient and outpatient, so probably about a fifth of the time as a registrar at King's you're doing inpatient work, and the rest of the time you're doing outpatient work, which also includes supporting other hospitals and working closely with other centres to kind of advise and help, because we cover such a broad area of the UK in each liver centre. And also I think it's easy to think you would only be doing liver things, but actually because of how multi-systemic a lot of our children's problems are, we end up doing a lot of general peds as well alongside liver stuff. You get to do procedures, so if you like that kind of thing, we do OGD, particularly managing varices and variceal bleeding. Is very multidisciplinary, so we work really closely with PICU, with surgeons, transplant coordinators, CNSs, dietitians, etc. And it's a very research-heavy specialty. So if you are interested in research, there are tons and tons of opportunities in hepatology. Everyone can get involved, and that goes from sort of clinical trials all the way down to more like lab-based research. So yeah, very happy to chat to anyone if they have any questions about it.
So first on my list is general paediatrics. I think we've got Hannah here. So if you don't mind, stop sharing the screen, James, and I'll hand over to Hannah. Thank you.
Thank you very much. Hi guys, and thank you all for being here. My name's Hannah Jacob. I'm a general paediatric consultant working in London. And I am going to try and convince you that general paediatrics is absolutely the best decision that you could ever make. I think the breadth of both clinical presentations and acuity, not to mention the ages that you see in general paediatrics, is really unrivaled. So I see brand new babies right up to just before their day, to patients who have acute problems, but also conditions. There's a huge amount of variety. I think we also have opportunities within general paediatrics to work in an acute setting in a hospital, but also in more of a community setting. There's a chance to be a part of subspecialties. So my special interest is safeguarding, and I'm the named doctor for child safeguarding, but I have colleagues who have subspecialty interest in almost all the subspecialties as part of the general paediatric team. I think also general paediatrics particularly has a very multi-professional approach, and I've got access to, you know, working really closely with nursing colleagues, physio colleagues, occupational therapists, physiotherapists, speech and language therapists, dietitians, just to name a few, who all form part of the care that we provide both acutely and for children and young people with long-term conditions. I think there's a lot of opportunity within pediatrics to bring in other aspects of your training that you might be particularly interested in. So thinking about research, there's a big growing emphasis on general pediatric research around education and training, if that's something that interests you, lots of management and leadership opportunities. And of course, as a generalist, you're very well placed often to take on those kind of roles. We'll have an opportunity to answer more questions later on, but the headline is do general paediatrics.
Thank you, Hannah. And I'll just point out as well, general paediatrics is the only subspecialty at the moment that you don't have to apply for. So yeah, talk to Hannah more about that in the room. So the next subspecialty we have is community child health.
Hello, my name's Paul Wright. I'm the community CSAT lead for Kent, Surrey and Sussex. I'm going to encourage you to do community child health. You've got a wide variety of things that you can do. You can be someone like me, who's much more of a neurodisability specialist, or you can do a lot of work with children with sort of neurodivergence, or I've got colleagues who just purely do safeguarding, others who just look after children in care, looked after children, unaccompanied asylum-seeking children as well. And we also vary into things like child public health. The other thing is long-term working with patients and families. I'm just about to say goodbye to a young person who's turned 19. I first met him and his parents when he was 6 months of age, and he's been my patient ever since. So that's 18.5 years of care of that one young person. So it's a huge, wide variety, huge area. Come and join me. We've got one of my colleagues as well in our training room, and we'll be able to speak to you more about it.
Thanks, Paul. Next, we have neonatal medicine.
I think Morag was going to do this. Morag, are you there? There you go. To IT tech problems. I'm just going to put myself away again.
Okay. Okay, I'm Morag Campbell. I'm the outgoing chair of neonatal CSAC, and I'm going to tell you why you really want to come and do neonatal medicine. With lots of subspecialties, you end up working within a relatively narrow range, but in neonatal medicine, you look after everything from normal newborn babies in postnatal ward to the very sick preterm babies in the neonatal unit, to babies who are born with various congenital or surgical problems, requiring surgery in the first few days of life. And we work in partnership with families. We develop close relationships with the parents of our babies and work with them for them to be part of the caregivers within our intensive care settings. We not only look after babies while they're with us as inpatients, but we follow them up until the age of 2 years so that we can see what the developmental outcomes are. Lots of things in neonatal medicine we're getting better at. We have fewer babies that we're intubating. We like a less interventionist approach, but at the same time, we're at the cutting edge of medicine. We are seeing new populations of babies who are currently being looked after in our neonatal units, those born at 22 and 23 weeks gestation, where the evidence for the planned ways of care is very limited. And therefore, in addition to being a very clinically hands-on specialty, we're also very much research-driven specialty, because we're still at the process of developing the evidence base for the care we deliver. So if you want to come along to the neonatal room, we can talk to you about applying for neonatal medicine and also answer any questions you've got to one of our trainees who's joining us. Thank you.
Thank you, Morag. Next, we have paediatric immunology and infectious diseases.
Hello, my name is Catherine O'Sullivan. I'm an paediatric immunologist at Addenbrooke's in Cambridge, and I'm on the CSAC for Peds, IM and ID. So in the breakout room, we can talk about this a bit more, but essentially the big things that it's worth knowing about the subspecialty up front is the variety, because in the subspecialty we're training both immunologists, so people like myself, we're training pediatric infectious diseases consultants, and we're training people who do both. So there are some people who are ID consultants with a bit of immunology interest, and vice versa. So there is kind of a wide breadth of opportunities of how to use what you learn in the subspecialty and how to sort of forge the type of career and look for the type of jobs that you want at the end. And because of the nature of covering infectious diseases and immunology, we also cover loads of additional interesting stuff. So from the point of view of the immunology side, there's also loads of opportunities to learn about curative therapies in immunology, like bone marrow transplant, thymus transplant, gene therapy. And from the infectious disease side of things, there's the elements of investigating and managing in all different kinds of infections, but also pieces of work around vaccination, around health promotion. So there's loads of different aspects of both subspecialties, which are all combined together. We're a relatively small specialty in terms of numbers of centres around the country and numbers of consultants, so we all know each other very well. It's a very friendly specialty with really close networks, yeah, those are the main things. So happy to answer any questions in the breakout session.
Thank you, Catherine. And next we have a paediatric intensive care medicine.
Hello, I'm Kim Sykes and I'm the chair of the paediatric ISAC. And we offer a 2.5-year subspecialty training programme in Pickham. Our main remit of care in paediatrics is the resuscitation, the stabilisation, the transport, and most importantly, the ongoing care of critically ill and injured children and young people up to the age of 16. In this specialty, you'll learn to work with a wide MDT, which not only includes the staff on your base paediatric intensive care, but staff within your partner district general hospitals and in the operating theatre. Entry to the subspecialty can be from paediatrics, but also from anaesthesia, from ICM, and from the emergency department. We have a number of consultants in the subspecialty who have dual jobs. There's a range of subspecialties that you can develop an interest in during your career, including cardiac, transplant, and research. So loads of opportunities for ongoing development. In terms of your day-to-day practice, it's a very physiology, problem-based practice. We're a craft specialty, so you are required to develop lots of technical skills, which appeals to lots of people. And there's a broad pathway of patients that come through the unit, both the very acutely unwell patients, as well as increasingly a demographic of patients who have a chronic need for intensive care admissions. Increasingly, we are using more advanced technology, including the use of diagnostic genomics. And there are lots of opportunities, and in fact we encourage within the specialty you to develop your career from the acute hands-on ward-based practice to perhaps taking on a more international or charity-based role, or moving into research or management or education in order to prolong your career within a challenging subspecialty. So come along and we can tell you more about the different training pathways that you might be able to experience. So hope to see you later.
Thank you, Kim, and thanks to all the subspecialists so far. We do have a couple more presentations before we then have the second round of introduction. So, James, if we could have the slides back up, please. And I'd just like to introduce Dr. Karin Schwarz, our Assistant Officer for Recruitment, and she's going to talk about shortlisting and the interview process and assessment domains. Thank you.
Hiya, thanks, Eloise. Okay, so you've submitted your eligibility form, and now it comes to the shortlisting. The applications are submitted through Oriel, which you're hopefully familiar with already. You will find that the questions are quite structured. You'll have per domain, you'll have 2 or 3 questions, and you'll have a maximum 50-word limit. So you need to think a little bit about how you answer the question and how to submit your evidence. As said earlier, the clinical experience and the QI and audit examples must be the same as the confirmation of eligibility form. So, but that means it's something you have already done and have already had time to think about. Just watch it on e-portfolio that your answers aren't too long, because there isn't a function to have a 50-word limit, and you will only be able to paste 50 words per answer into the Oriel application. What we want from you is what you think is your best and your most relevant example for the assessment domains. This is to make it a little bit easier for scoring and for yourself as well. When we are not so much looking at the breadth, but at your best example. Nevertheless, you will have opportunity to bring in your other examples in other parts of the shortlisting and the interview process. So I don't think you will lose out if you've got several very good examples and you're finding it hard to choose. That's probably an indication that you're a strong candidate, because you've got loads of good examples and you will have opportunity to bring them in later. And you will need to upload the evidence for those examples, and in particular for the publication, presentation, poster, so for that domain. So the assessment domains you can see down here, there's 6 of them. The clinical experience and exploration of subspecialty, this will be 3 best examples of clinical experience you have in relation to the subspecialty. So we're not looking for somebody who's done loads and loads of subspecialty experience. We are looking for somebody who can demonstrate that they have that they're suited to the specialty and that they're suited to the specialty and that they have a real interest in the specialty. So you don't need to demonstrate that you're basically a subspecialist already. So you may have for an example from experience in another specialty or in general pediatrics that actually relates to what will be relevant in your subspecialty, and recognizing what is relevant in your subspecialty again shows that you have explored the subspecialty and you have looked at what it has to offer. So you may use some communication experience or some examples of good communication for the subspecialties where that is particularly relevant, maybe like palliative care, or you may be using some experience some practical experience. Maybe you're very good at putting lines in and intubating babies and neonates, and that may be relevant to an application for PICU, for example. Leadership and management. We're looking at one particular, at your best example in that area. It can be leadership and management anywhere. It doesn't need to be specifically, we're not looking for clinical leadership experience, and it doesn't have to be specifically in the medical field, but it should relate to your application. So you may have led an immunization campaign, or you may have been in BAPAM, a rep in your hospital or for an organization, and those sort of things will be good examples. And what we're looking for is your input into that role and what you have learned from it. So it's useful to describe what you have actually done, what your time commitment was, and how it has furthered your career. Quality improvement and audit, again, your most significant example, you should have already had that on your eligibility form. And what we would like you to do is to demonstrate an understanding of the process and demonstrate that you have had a significant involvement in this project or audit, and that it has either confirmed that current practice is good or that it has led to a change in practice. And again, you may get more points for a smaller audit project that you have completely managed yourself than maybe participation in a large national audit. Education, again, is similar. Your best example, have you just delivered teaching, or have you actually designed it from scratch? Have you looked at getting feedback on your teaching, and have you used that feedback to improve your teaching in future? There's also a slight difference in whether it is for local team or for regional team, but the main thing for us is whether you can show that you've had an active part in developing and progressing this teaching. There will be a point to be had for teaching qualifications, but this is only for significant qualifications. So usually it would have been at the level, as a minimum, at the level of a certificate, which would be a part-time commitment for over a year usually. So training the trainers or similar, or would not get you any points. Publications are probably the most complicated one. Please read our guidance in detail. We have a lot of effort and has gone into that to get it right. There are probably still things that don't quite fit into it or aren't quite right, but we've tried to make it as fair as possible and give more points for more important publications, but also for those where you have had a major role in them. So it'll probably go from simplified from a case report to being maybe a co-author to having a first author peer-reviewed article. But there's loads of other research projects in between there, and you'll find that in our guidance as to how many points in terms of shortlisting those would attract. And try and give us as much information as you can on the form to make it easier for the people shortlisting to determine what the reward for that should be in terms of shortlisting. Okay, thank you. So interviews are going to continue to be virtual on Cubacom. You'll get separate training for that if you're going to interview. They have been extended, and it'll be 30 minutes. They will be single or two-part questions, and you will be told whether it's a single or two-part question, and you will also get help to make sure that you know how much time you have for each question, so that you don't, on a two-part question, spend loads of time on part one and then don't have time for part two. In general, time is allocated equally between the domains. We, as we said earlier, the shortlisting score will not feed into the overall score. It'll just get you through to interview, and we will be aiming. It will depend on how many posts are available in each specialty as to how many people we shortlist, but the aim will be to shortlist and get through to interview as many people as we can manage within the system, to give you all a good chance of actually getting an interview. So the assessment domains for the interviews haven't changed since last year, and they're designed to complement what's been looked at in the shortlisting. So the motivation for your specialty, that's your question that you can sort of predict is going to come up. That's your opportunity to shine. It's one that you can fairly well prepare in advance. And it's the question where you can use all the other stuff you've done in relation to the specialty that you haven't been able to put into the shortlisting. You can mention all those things and tell the interviewers why they are relevant for your preparation for the specialty. Remember, we're looking for people who are suited to the specialty in terms of their skills, but we're also looking for people who are really, really passionate about the specialty, and that's something that needs to come through in that answer. The clinical ability and reasoning will be a clinical question, but based on the subspecialty, but we are not expecting that you have detailed subspecialty knowledge at this stage. What we're expecting you is to have a good approach, demonstrate that you're a safe doctor who will be looking for, will start a management plan and will be looking for advice as needed. There will not be anything that you wouldn't have come across at all in your general pediatric training so far, even if you haven't had a job in the subspecialty. The academic achievements and understanding will be research and teaching based. You will either get a more generic question, or you will be asked about what your experience and what you have done in this area of your work. And the clinical leadership question will be a second clinical scenario, but rather than demonstrating on the management of the patient, it will demonstrate on how you manage your team and how you work together with other people to resolve a clinical situation. And so that will give you 7.5 minutes for each of those questions. And so, yeah, good luck with that. Thank you, Eloise.
Thanks, Karen. And now I'd like to introduce Dr Natalie Wyatt, who is in training, in nephrology training, and she's just going to talk to you a bit about how to gain experience in a subspecialty. Thanks, Natalie.
No problem. Hello, everybody. So yeah, just a brief few minutes on gaining experiences. I know that this can be quite anxiety provoking for some people, especially if you live or work in an area where you haven't got the subspecialty that you're interested in training in. But there are lots of different ways of gaining experience. Number one, so that you understand more about the subspecialty and be more certain that you want to do it, but also about gaining experience to demonstrate your commitment in terms of applications. So the lovely team at the RCPCH have provided me with this slide, which I think has some really useful information on it. I know the applications are coming up relatively soon now in October, but still I think talking to your training program director about rotations in that subspecialty is something that's worthwhile doing. Hopefully you will all get your first round applications done, and you'll get a place. I didn't. It took me 2 goes to get the subspecialty job I wanted. So actually speaking to my TPD and getting a rotation in that subspecialty in place was really helpful, because then when I came to reapply, I had a much better confidence in myself that this was what I wanted to do, but also some really good experience to discuss at interview and on applications. Even if you can't manage a rotation, so don't forget about taking some study leave time and going to do some taster sessions, attending clinic. Even if you don't manage to make it to a tertiary clinic, just prioritising going to the clinics within your district general, for example, within the general paediatrics department. So for example, for me, I tried to prioritise all of my SD4 clinic experience in general paediatrics into the Gen Peds renal clinic as much as possible. And that again was a really useful way of gaining experience. Talking to consultants and trainees is, I think, probably the best thing that you can do. Even if you don't know anyone, I think across the specialties, everybody is very approachable. On the RCPCH website, you have the email addresses for the CSACs. You also obviously can just call up the local tertiary specialty service. So for example, there's always somebody on the phone where I work as a registrar, and I've had someone call me before and say, I'm interested in doing paediatric nephrology. I don't know how to get involved in a project or get something going. I just gave them my email address and we sorted out some contacts for them. So that's also it. If you don't know anyone already, there's lots of different ways of finding them. Go through the CSAC emails, or just, take the initiative and get in contact with the local team. One of the things that I recommend to some of the nephrology interested ones is they come to our training days. So for example, we have twice a year training days, and there often is a good number of people at those days that are not in training but are interested. And I think, again, a really useful place to meet people, so you can get involved with projects, you can get a sense of what's going on in the specialty, but also to gain some experience. Use your study leave, go to the conferences, go to the events. A sweeping statement, but I would hazard a guess that all of the subspecialties have their own national organisation as well as international organisations, all of which will be running conferences and events. They're really useful things to go to. In your department at work, talk about projects in the field that you might do. So if you're interested in neonates, even if you're in the general paediatrics department, you could start a project looking at how you can improve the care of infants turning up in ED, for example. There's always something that you can get involved with wherever you are that you can link across to the subspecialty that you're interested in. It's also a good idea to have a think about in all aspects of what you're doing, how you can link that into the subspecialty you're interested in. So for example, if you want to do a postgraduate teaching qualification, or you're interested in doing any of the postgraduate courses like the master's programs that are on offer that all run flexibly, well, a lot of them run flexibly, so you can do them alongside your clinical work. You can do things like that and slant all of the project work that you do within those toward the subspecialty that you're interested in. So for example, I did a master's program and I did basically all of the modules. I tried to find how can I do the case study or the dissertation, or how can I do it in a way that helps me build skills in paediatric nephrology as well. So those are just some of the other interesting things to think about. I think probably the key thing is just finding a person, getting in contact with somebody who's already in the specialty to kind of support you to all the different avenues of ways of demonstrating your enthusiasm and gaining experience. Thank you.
Thank you so much, Natalie. Really useful information there. Thank you. And you're going to be in the subspecialty stall as well, I think. So go and chat to Natalie more there. Thank you. So now we have a trainee. I'd like to introduce us to the presentation, Cheryl Githinji from Palliative Medicine. Thank you, Cheryl.
Hi there. Sorry, I'm just going to share slides quickly. It's just about how to apply and sort of gaining experience within the subspecialty, which I'll present on quickly. Just bear with me when I share slides. Oh dear. Can you see those?
Yes.
Okay, that's great. So it's a very, very brief sort of talk on how to apply for the subspecialty and why I chose paediatric palliative medicine. I'll be talking about this again briefly in a little bit. But really is that I sort of had the idea, was in respiratory medicine at the time, conversations with my educational supervisor, who then suggested actually is palliative medicine a possibility for you, because I liked the idea of the wide breadth of patients that we saw, the complexity of it, and the sort of multidisciplinary team working that we did. And I'll go into that a bit later and in the breakout rooms as well. But the main things is just having those conversations initially, having the idea, speak to your supervisor, who often are very helpful in sort of pointing you in the right direction as to where else you can go to either get more experience or have conversations with the right sort of subspecialty to be able to understand if that subspecialty is actually for you. From then on, having had those conversations, I was then able to speak to our local paediatric palliative care team, and sort of just took study leave to spend a day understanding what the specialties are like, going around seeing patients and then reflecting on that and putting it in my portfolio as sort of evidence of my A, clinical interest, and B, sort of evidence of sort of experience as well. And then there's sort of lots of options from that point on as to what you can do. Sorry, just things are in the way. In terms of how else you can gain experience. So obviously, if you've got a team locally, try and join them. Secondly, it's thinking about whether you can speak to your TPD and request placements in that specialty. Pediatric palliative medicine is quite small, and so actually I took the opportunity to request placements in things like oncology, so I can have some experience there. Requested PICU, requested respiratory was also really helpful. And it's always thinking about that broader experience that you can get to sort of link as evidence for the subspecialty you may want to train in. And then on top of that, it's thinking about conferences and things like that. Palliative medicine's great, and all the subspecialties will have sort of their own specialty groups. For us, it's the Association of Paediatric Palliative Medicine. They hold a yearly conference, and I just made sure I sort of attended that, again, evidenced it, reflected on it, put it on my portfolio, and used it as my evidence towards applying for paediatric palliative medicine. And then also one thing that's really useful is trying to get projects done. Again, in DGH's palliative medicine in particular is quite a small specialty, but there's always opportunity to do projects, whether that's QI projects or posters or guidelines updating and things like that you can just, again, discuss with your supervisors. And there's often a clinical need for that within your department. And so just being curious, asking the right questions, and then often you can get the experience that will be quite useful for your application. And it's also thinking about creative ways of using that to sort of sell yourself in your application for long listing and shortlisting. But that's that for now. If I can figure out how to stop sharing. I know that's really brief, but hopefully I can answer a few more questions later on.
That's really helpful, Cheryl. Thank you. Really great. So we'll just move into the second round of subspecialty introductions before we then open the subspecialty stall. So running a little bit over, so I think the rooms will probably open about 5 past, so hopefully that's okay. So if you could stay with us till then. So first we have a representative from Paediatric Inherited Metabolic Medicine. I think we've got Emma with us.
Mm-hmm. Good morning. Hi,
Emma.
can you hear me? Morning. Hi.
Yes,
No, I'm Emma Footit. I'm a metabolic consultant in Great Ormond Street Hospital. Just a brief overview of the specialty. So we are a small specialty. There's just a few UK training centres, so namely in London, Birmingham, Manchester and Scotland. And I think this does need to be considered when you're considering choices. As consultants in the specialty, we diagnose and manage patients with individually very rare genetic diseases that affect sort of one or more metabolic pathways. And some of the sort of more common groups that you might be familiar with would be sort of urea cycle disorders, some of the mitochondrial conditions, galactosemia, for example. But actually, there are hundreds of individual rare genetic diseases that we manage. Children with these conditions present with a diverse range of problems. Many of these are multi-system, hence we're often working alongside other specialties in the hospital, but also within the community. So teamwork and communication, I would say, are really important factors within our specialty. An increasing number of metabolic diseases are screened for on the newborn screening programme. So many of the patients that we look after are actually quite well, and we're managing disease preventatively, which is a really nice aspect of the specialty, I would say. Our treatment approaches in many cases are dietary manipulation. So we work very closely and on a daily basis really with specialist dietitians and nursing teams as well. In contrast, unfortunately, some of the disorders we look after are life limiting. And so we therefore sometimes also work with palliative and symptom care teams, needing to sort of break bad news, manage uncertainty, and certainly manage some end of life discussions as well. And that may be in the community or in the sort of intensive care setting. So I think I've already alluded to, it's quite a varied specialty. Day-to-day work, the clinical work is varied. A large proportion of our work, I would say, is outpatient based. So when we're not on call, we're often managing families in an outpatient setting alongside nursing and dietetic colleagues. And these will be families that you will know for years. And for me, this is a really rewarding part of the career. When you're on call, it's slightly different. You'll be managing acutely presenting patients on an inpatient ward, potentially in intensive care. Many of these may be new cases where the diagnostic workup is important. And in other cases, it will be management of an acute decompensation. And then finally, as I think you've heard from many other specialties, metabolic medicine sits very much on the cutting edge of research, I would say, for novel therapies and interventions. And many of our patients are now part of clinical trials, perhaps receiving first in man for gene therapy, for example. So there's great opportunities for trainees and consultants to develop a research interest within the career. That may be a clinical research interest or may even be sort of basic science and lab-based work. And several of our trainees and consultants will do PhDs, although this isn't a necessary requirement. So I think finally, just to say that I think paediatric metabolic medicine is a very exciting specialty. I think particularly in the coming years when we're going to see more and more novel therapies coming to be available for the patient population. So it really is an exciting time to be in this specialty. It's very varied, there's lots of team working, and I would say there's never a dull day in our specialty. So please do consider it.
Thank you, Emma. Next, we have paediatric neurodisability.
Hello,
Hi, Jill.
my name's Jill Cadogan. I'm a paediatrician in neurodisability at the Evelina London Children's Hospital. I just wanted to, I'm just hopefully sharing my screen. So neurodisability is a really exciting specialty where you have a career focused on holistic care of children and young people and their families with complex chronic disease. I always say to people, it's like you have to be a really good general paediatrician with the background distractor of a very complex, often neurological condition or other complex chronic disease, genetic condition. We have a real focus on function participation. So improving people's lives and young people's lives with a very ICF framework approach to helping with them. We work with a lot of different subspecialists. And there are new emerging treatments, as for all, gene therapies. We're changing the SMA phenotype, and all of these children need long-term care. Wide range of career options, both tertiary and secondary, community or acute-based, and academic or clinical lead. So we have a 3-year training programme, which includes community placements, neurology placements, and neurodevelopmental neurodisability placements. And yeah, we are a great bunch of clinicians across the country. We have a fantastic organisation, the British Academy of Childhood Disability, which will have loads of information for you about approaching people, research activities, teaching and training, and having a true MDT approach to your career. Thank you.
Thanks, Jill. Okay, so next we have paediatric palliative medicine.
Hi, it's me again. Sorry, I realised I didn't introduce myself properly before. I'm Cheryl. I'm one of the paediatric palliative care registrars over at the Evelina London Children's Hospital. I will just share my screen again. Bear with me. So why do paediatric palliative medicine? Main reason, actually, if that's showing up okay.
Yes.
Yes, so the main reason for me is that we'll focus on what really matters and what matters for families. we often are the team that called on to sort of improve quality of life. I went into pediatric palliative medicine mostly because, you know, families are given the worst news of their life, and it's a decision that often can't be changed. And I am interested in making sure that those last few days, months, years matter more than anything to the family. And so it's focusing on what the family want and what is needed for them. So it's very holistic, and this sort of focus on quality of life. But from a medicine point of view, I love the fact that it's not a single organ specialty. We work looking at the child as a whole. And again, as Dr. Cadogan said about being very good at general pediatrician, that I think applies here as well. But also we focus a lot on sort of communication skills, and that is our sort of our key skill really that we've picked up from med school and use on a day-to-day basis. And it's often breaking bad news, so supporting families through the most difficult time of their lives, and talking about options and what the next best steps are, and thinking about the clinical implications for the child and what's in the best interests, and making sure that is like adhered to and works for that family. But also from a physiology and pharmacology point of view, it's quite interesting. End-of-life care is, you know, symptoms that arise at that point in time. We're often dealing with children who've been on multiple medications throughout their lives and lots of polypharmacy, but then thinking about the physiology of the end of life and the medications that can be used to sort of support them and leave them with as little of a symptom burden as possible, so that they, if they are and when they're dying, that they you know, that's they do not experience any suffering. But also the job, we work as a multidisciplinary team. Within our teams is often a large cohort of clinical nurse specialists, but also pharmacists, specialist pharmacists in pediatric palliative care, but also thinking a lot about the family and the sort of psychological impact on them. We'll often work with social workers, psychology and family support workers to be able to provide that sort of holistic care. The job itself is relatively flexible. And with that, I mean, depending on where the teams are around the country, some are based in hospice, some are based in a hospital, but all of us work very flexibly, being able to see patients at home, in community, whether that's district generals in their own homes, within the hospital, on the wards and tertiary centres, or sometimes running sort of outpatient outreach clinics in hospices at sort of special schools around the country. And I really like that ability to sort of see patients where sort of not in a clinical environment sometimes. And yes, I think it's a great specialty if you want to, if you're a good communicator, you're interested in the interesting pharmacology and physiology, and you like the flexibility. But yeah, that's sort of where we're at.
Thank you, Cheryl. And for this morning's session, the last introduction we have is from the representative from Paediatric Respiratory Medicine, please.
Hi, good morning, everyone. I'm really pleased that you've left the best till last. So my name's Gemma Saint. I'm a respiratory and sleep and LTV consultant at Alder Hey Children's Hospital. And I include my full title there because I think it's really important that people realise respiratory isn't just respiratory. It also includes long-term ventilation and sleep medicine. So it's a very rich and varied specialty to choose, and one that I find incredibly rewarding. I think one of the biggest strengths of respiratory medicine is the nature of the work, in that you're constantly part of a multidisciplinary team, including physiotherapists, speech language therapists, nurses, dietitians, psychologists. And I think that that kind of strong dynamic not only enhances the patient care that you give to your patients and young people, but it also makes day-to-day work much more enjoyable. I enjoy coming to work and working with the varied members of that team. And I think enjoying your job is key to doing it well. So the specialty itself is diverse. It covers asthma, cystic fibrosis, sleep medicine, ventilation, and rare lung diseases. And it much more than that I couldn't possibly fit into 1 minute. There's always something new to learn, and there's lots of opportunities to develop subspecialty interest. So, you know, you can go deeper into the sleep medicine or the ventilation or the bronchiectasis or difficult asthma. I think what sets paediatric respiratory apart, in my opinion, is it's a very friendly, inclusive culture. And you coordinate with lots of other disciplines, so PICU, ENT, community, palliative. It's a very dynamic role. So I think paediatric respiratory would suit somebody who enjoys problem solving and managing complex long-term conditions. I think it's ideal for those who thrive in a team environment that's busy and values good communication and wants to build lasting relationships with families, because we often know our young people from birth through to when we transition them into adults. So if you're someone who likes variety, collaboration and seeing the impact of your care over time, I think respiratory would be a really good fit for you. Perhaps I'm a little bit biased, but I wouldn't want to do any other specialty. Thanks very much.
Thank you very much, Gemma, and paediatric nephrology. But I think we've got Matt Coe here from that subspecialty.
Thanks, Eloise. Thanks, everyone. I'm Matt Comani. I'm a nephrologist in London and CSAC training advisor. Paediatric nephrology is clearly the best specialty. I love it. I think my quality of life professionally is fantastic, and I can't recommend it enough. We have a perfect mix of acute versus chronic, short-term cases that you hopefully solve and then send them on their way with limited follow-up. And we have cases where I see them antenatally and then I might see them when they're up to 18 years old. So we have a good balance of that. I think another really nice thing about our specialty is that we're a good balance of medical and surgical. Our ward has a lot of medical patients, but actually we have a lot of surgical patients with our kidney transplant surgeons and also with our urologists. So you have a good mix of different cases if you're interested in a broad range of issues. We're a relatively small specialty, not the smallest, but we're relatively small. So most of us will know most of the other UK consultants. So you're always there with the option of phoning a friend. And what I would really say is, this applies to many subspecialties, but particularly I think to nephrology, is you can really focus on a small area of medicine, and in my opinion you can become quite good at that. It's quite hard to do that in a very broad field, but actually in a small specialty it's easier to do that, and I think for me that provides me with a greater deal of professional satisfaction. I appreciate that's not for everyone. It would be great to talk to you more. Unfortunately I can't be in the stalls, but I know Natalie and Doug, one of our colleagues, is going to be there, so please come and talk to us. Thank you.
Thank you, Matt Coe. Okay, so next we have paediatric neurology. Hi, Audrey.
Hi, everyone. My name is Audrey Su, and I'm a paediatric neurology subspecialty trainee in London. And if you're a curious clinician who loves working in MDT and want to work with kind, friendly, hardworking colleagues and love helping children to reach their full potential, do consider joining the wonderful world of paediatric neurology. And whether it's common conditions like epilepsy to the rare neurogenetic disorders, from a stroke affecting the central nervous system to a neuromuscular condition affecting the peripheral nervous system, from brain tumors to neuroinflammatory conditions, from acute to chronic conditions, there is so much variety, and every day is so exciting and never boring. So there's also never been a time with better diagnostics and more efficacious disease-modifying treatments available for children with neurological disorders, including licensed gene therapies that is transforming the natural history of many conditions. And there are so many exciting developments in pediatric neurology and so many reasons to be hopeful. So please do come check out the neurology stall to meet a few of us neurologists. Thank you.
Thank you, Audrey. And next we have paediatric oncology.
Hi, I'm Nilakshi. I'm one of the pediatric oncology grade trainees in London. And if I have 1 minute to sum up my subspecialty, I would use the word journey many times because for me, this has been a rewarding journey alongside some amazing children, young people and their families that I've worked with, their courage complementing the compassion and care we provide while looking after them. It is a journey of togetherness because we work as part of the biggest multidisciplinary teams and including medical and surgical specialties, allied health professionals, and not just within a tertiary center. We work very closely with our shared care colleagues in the secondary primary care and the community. It is going to be a journey of innovation because I think this is a specialty where you see the fastest translation of research from bench to bedside, with less toxic care coming in more and more into frontline therapy, as we are now using immunotherapy as frontline for acute leukemia as well. And I think I would just reflect a little bit on my personal journey. I developed interest in this subspecialty when I was working in India, which is a resource-limited setting. And now I work in with some of the greatest oncologists in the world, but I see the compassion and care and the way they work collaboratively with lower middle income countries to make sure that innovation is not just restricted to a few of us here, but it reaches out to all the children and young people who are diagnosed with cancer across the globe. So I'm hoping to see a lot of you in the subspecialty stalls, and please feel free to contact me as well. Thank you.
You. And last but not least, we have paediatric rheumatology.
Thanks, Eloise, very much.
Thank you.
Well, certainly, I'm Jo Walsh. I'm a paediatric rheumatologist up in Glasgow, and I have the opportunity also to work across our national SPARN network in Scotland. Last but not least, as Eloise says, paediatric and adolescent rheumatology is just the best specialty. 1 minute will never do it justice. So please really do drop into the rheumatology room, the room as we call it, to find out more from myself and also grid trainee Ryan Lethen about what it's like to train in our small but really fantastic subspecialty. I'll show you some descriptive words. We are one of the smaller subspecialties, but because of that means we work as a community in the UK, but also wider nationally and internationally. We're inclusive, we're welcoming, and we support our trainees incredibly. Many of us will work in clinical networks to facilitate patient care, which is what we're about. We have a huge scope of conditions that we look after, many inflammatory, but not all, from the very benign to some very critical presentations. And it's that variety that keeps us on our toes. It's a thinking specialty. We're often going, what on earth are we dealing with? And how do we apply first principles? We've had a surge of new diagnosis, and this is mentioned by other subspecialties, and our conditions evolve as we have genetic advances and things. We're practical subspecialty. We will find ourselves in theatre doing joint injections, putting steroid into small joints. So if that appeals to you, again, come and join and hear more about what we do. And our treatments, ever evolving, very much cutting edge, using biologics and inflammatory modulators. So because we look after inflammation, this happens to across the board in the subspecialties, and we find ourselves collaborating with really everyone in the hospital, including all the subspecialties, in particular ophthalmology, orthopedics, genetics, ID and immunology. But really I find myself on the doorstep of everyone, often lending a hand with inflammatory conditions. Our MDT is the heart of what we do, and we have a really varied day-to-day workload. I think, come and hear what we have to say. I just want to leave you with the fact that I have just moved on a young person who I met at the age of 18 months, and she's transitioned to young adult care with a diagnosis of juvenile arthritis, now aged 18. It's a real privilege to work with our young people and their families. So do come and join us in the room, and we'd like to see you there.
Thank you, Jo, and thank you again to all our subspecialty representatives talking in this afternoon session. James, if you could just put the slides back up. I've just got a couple more short slides before we open the rooms. Okay, so what to do next? So 2 different groups here. If you are eligible to apply in the next round, you're feeling ready, what should you do next? So arrange to meet with your educational supervisor, talk to them about your application, have some career discussions, start thinking about your examples for your confirmation of eligibility form and your application form, and start preparing early for your application. Don't leave it till last minute to submit your application. Prepare early. If you're not eligible to apply yet, or you're not feeling ready, so depending on where you're at, it might be that you're not on the UK paediatric training programme yet. So that'd be the first stage. So get yourself onto the paediatric training programme. As Natalie said earlier, you can speak to your colleagues that you work with, or try and contact people that work in paediatric subspecialties that you're interested in. And if you are in training, but not quite at the stage where you're ready to apply, start having discussions with your educational supervisor, your head of school or training program director about your career choices, and perhaps you could get a placement in one of the subspecialties. Okay, so my final slide leading into the QA, if there are any questions, we'll come to those, but I think some have been answered as we've been going along. So next slide, sorry, James, please. Okay, so what's next? All the applicant guidance will be available on our website by the end of July. There will be some being posted tomorrow, including the dates. We always hold a webinar on the application process in September, so that date will be available once it's been confirmed. And the programmes will be available to view on our website and then SharePoint as well from Wednesday, the 8th of October. So you can see our website there under applicant guidance, and we have a web page for all the subspecialties that you can apply for. So have a look there, and they can contact us on that email, the medical recruitment team. There's a QR code on the screen at the moment. It's the same link which is on your programme. We really welcome your feedback on this event, on the opening talks or the breakout rooms. So, are there any questions, James, in the chat? Because I think that's everything I plan to go through.
There are none in the Q&A, but there are a couple coming through the chat. I've replied to several of them just so we can try and get you through to the stalls. But I'll just, that last one there about if you're starting ST3 this September and you've completed your exams, can you apply to start next year? I just want to just make that again quite clear. The key to being eligible to apply is that you need to have got your core training signed off by next August or September. And it shouldn't be done kind of preemptively either. So if there's any doubt, that is going to be the case, then, you've got plenty of time to apply. And actually, if you get to a point, and this has happened, certainly, that, somebody has tried to organise sort of progressing quicker through their training in advance with their supervisor, they've then actually reached the point where they're going to start their subspecialty post and have actually not been fully signed off, so they've had to give it up. So think carefully. You need to be absolutely on track if you're going to try and consider that. But so you've got so much time left in training, there really is no need to rush it, and you're better off just being certain that you're in the right place when you apply, essentially. And yeah, just to reiterate around those conversations with educational supervisors. So a couple of weeks ago, we held a educational supervisor roadshow. So they have all been kind of fully briefed, and actually, hopefully, a lot of you have already been contacted by them to start putting those careers discussions meetings in the calendar already. If they haven't, then you must start trying to do that now. So it'll be your current educational supervisor that is the person that you're going to be working with on the application form and trying to get your confirmation of eligibility form signed off. But other than that, I think we'll try and get the stalls open, shall we, Eloise?
Yes. Sorry, did I just see a question just came through, or perhaps it's already been asked? Is there any new questions?
Just an acknowledgement, I think.
No. Okay, great.
Yeah.
All right. Well, yes. So all the subspecialty rooms, they're now open. So you've got, for the next 2 hours, your time, you can move around freely. Just click on the links on the programme. And yeah, hope you have an enjoyable afternoon. Kim.